Welcome to Early Detect Studios. Today, we are thrilled to have Mr. Dave Richard, Senior Vice President of Government Relations for McGuireWoods Consulting. Prior to his current role, Mr. Richard served as North Carolina's Deputy Secretary for Medicaid for 8 years, where his vision was to ensure a sustainable Medicaid program for the 2 million plus North Carolina Medicaid beneficiaries that was person-centered, innovative, and cost-effective. Mr. Richard joined the Department of Health and Human Services in 2013 as Director of the Division of Mental Health, Developmental Disabilities, and Substance Abuse Services. He previously served 24 years as the Executive Director for the ARC of North Carolina. A proud Louisiana State University graduate, he was an education major in college, and as a fun fact, he started his career teaching middle school history, English, math, and science, and even coached football. It is through these early career experiences that Mr. Richard credits learning a lot about managing people. Dave, welcome to the studio.
Thanks so much, Sheena. Happy to be here.
Absolutely. So upon your departure as Medicaid Director earlier this year, the DHHS stated, "Few have done more to improve the health and well-being of North Carolinians." And that's a quote. The quote continues to say that Dave leaves North Carolina Medicaid stable and strong with a robust team of leaders to carry the torch. So we can clearly see how dedicated you were as a public servant. And thus, before we delve into the questions about your leadership, to sort of set the stage, I would love to learn more about how you developed a passion for public health.
It's a great question, and I will say it's a very, very nice quote, and I'm not sure I deserve those comments. But I was actually, where I developed a passion as a teenager. I wound up volunteering with the ARC in Louisiana, where I grew up, and it was early days. We were doing summer camps and all sorts of other environments. But what really hooked me was getting to know families who had kids with significant disabilities. And as you might imagine, this was back in the early 70s, and there weren't a lot of services for people. And it's also recognizing that these families were doing just incredible things to support their sons and daughters, with significant disabilities, but their hopes and dreams were the same as any other family. And it was that sort of realization that folks have all sorts of circumstances that they live and grow up in, and that honestly, we as a society have I think, an obligation to do the right things by people. And so it evolved in terms of working in the ARC and doing that work, but learning more and more about not only the social side of that, but the health needs of people. And that, we as organizations can do so many good things for people if we put our mind to it and really listen to what folks are talking about. So it really came from those early years that I think my parents kind of forced me to be a volunteer to make sure I was on a straight and narrow in terms of what I did. But I thank them for that effort, and it's surely changed my life.
Wow, that's really remarkable. I think it's always beautiful to see how personal experiences convert into passion and purpose. So thank you for sharing that. So getting straight into your role as Medicaid Director, under your leadership, North Carolina Medicaid was recognized for developing quite a few innovative approaches. So, for example, the maternal and perinatal telehealth policy during COVID-19 that provided telehealth and home visit care to patients, that provided reimbursement to perinatal providers for remote blood pressure monitoring, physiological monitoring, and lactation services, and that conducted postpartum depression screenings by video, phone, and online portal messaging. I mean, this is all pretty innovative and really ahead of the curve. So can you share examples of how these or other innovative initiatives or technologies that you developed or oversaw during your time as Medicaid Director, how did they have a significant impact on reducing disparities and improving outcomes for your population?
Great question. And now, first I need to say is that we have had an incredible team at Medicaid. So I can't take credit for those things that would happen, but it was a team effort of folks working together to think about that. And as you know, as COVID hit, we all were trying to figure out what are the right steps that we should do. We've been working on issues around disparities, but frankly, COVID opened our eyes to disparities in a very different way than we had seen them before that. And I know we'll talk more about that. But the thing I think I'm most proud of is how quickly our team was able to change that. We were a typical bureaucracy that was slow to move on certain things. But with this, we realized that we couldn't wait. We had to change rapidly to make sure that all the things you mentioned were in place. I'm incredibly proud of that speed in which we were able to do that. I also, we don't mention it a lot, but, Medicaid during that period of time, CMS, allowed for states to, who hadn't expanded Medicaid, to do a minor expansion. That minor expansion was to allow for women postpartum to stay on Medicaid for a full year. Prior to that, it was 6 months after birth that it was saying, which, we all know that's not the right time, right? We had to have a lot longer then. So working with the General Assembly in North Carolina, and our team developed a proposal that I'm proud to say that was supported across the board to make that change in North Carolina. Now we'll talk more about it, but we just have expansion in North Carolina, which is a huge deal. But for women, this was an incredible move that happened during that period of time. So excited about that. And I'll say there were some little things that we figured out, right? We were looking at disparities across the agency, and we recognized that for sickle cell, we had a PA on a sickle cell drug. We never denied the sickle cell drug, but what it did is it delayed that ability for people to receive it, and frankly, sometimes was a barrier for people ever to get there. So with things like that I think what we recognized as we really began to delve into, how COVID impacted us, is that there were many things inside our agency that needed to change, regardless of COVID, but it gave us the impetus for doing several of those things.
Wow, that's fascinating. So given, CognitiveCare's mission, I simply had to ask, and this is, I guess, a continuation to the previous question, but as Medicaid director, what emphasis did you place on preventative care and early intervention to improve outcomes? And I know with COVID behind us, we were quite, in emergency situations, but generally speaking, over your duration as Medicaid director, what emphasis did you place on these elements?
It's a great question. And say I want to talk more about the great stuff that CognitiveCare is doing and how it's going to really just move us forward. But frankly, early in my tenure at Medicaid, I was learning a lot about the physical health side, right? Because I had come from long-term supports and services, from the disability community side of that. And one of the things that just initially that we recognized is that our rates for primary care were so far behind. And so what we believed, and again, from a lot of really smart folks helping me understand this, is we didn't do the right thing for primary care. In Medicaid, we would lose those docs. And if you lose those physicians inside of Medicaid, then frankly, you're just catching up all the time, right? You're on the back end, not doing preventative work. You're people in emergency departments. So one, we moved those rates up to the Medicare standards, which made a huge difference in keeping physicians inside of that. We'll talk about it later too. We were moving to a managed care system, which is not always the most exciting thing for physicians. So we had to do additional things to keep people there. And then we've had a long history in North Carolina of a medical home model for primary care. And what we were able to do is to make sure that model continued during this transition to managed care, so that what I'd say is the most important thing I think we did as an organization and continue to do is to emphasize that preventative work on a front end, right? If you're not seeing your primary care physician at a regular basis, then we're not going to catch up, right? It's a lot of folks talk about Medicaid programs. People show up in emergency departments all the time. Well, I think we have a much better ratio of people not doing that because of that emphasis on actually doing the work in the front end. Now, what I just add is that the things that I think are cool about thinking about you guys is that how do you actually begin to make those resources work and you put them in the right places at the right time? We're a rural state in North Carolina, and we have some places in the state that frankly look like third world countries in terms of our health outcomes. So managing that is going to be really important. And part of that effort was to think about how do you keep docs and frankly other primary care providers, nurse practitioners in those local communities to do the work. And that's still ongoing. It's a lot of work to get that place. But I think the early days of our work began to think about that differently. So really, I think that emphasis on primary care is one of the most important things that we were doing in North Carolina.
Absolutely. So, noting your extensive multi-decade leadership in behavioral health leading up to your appointment as Medicaid director, so now I'm going even further back, I was curious, how did your Medicaid programs and policies address the specific mental health and behavioral health needs of the North Carolina population?
Yeah, it's a great question. And I'll say that like every other state right now, I think we're all struggling on the mental health and behavioral health spectrum. The issues around substance use disorder and, the opioid crisis, frankly, the pandemic, what it's done in mental health is created I think it's strained our system in a way that we knew we had problems before, but that we really, really have to think new ways to address those. Early on, one of the things that we did in North Carolina is that we went to a community-based managed care system. And, sometimes, again, managed care gets a bad rap, but because it was community-based, embedded in counties, we have 100 counties in North Carolina, where a lot of these services are delivered. I think we changed the dynamic of how we think about delivering care. So it's not just, right? So you think about behavioral health and physical health on the side, but we added the social determinants as part of that management. So, I like to say is that, in the behavioral health world, we were doing social determinants before social determinants were cool, right? So we understood that. We understood the housing needs, really working to do that effort early on in North Carolina. But as we move forward, the other thing that we recognize is that we're never going to have enough psychiatrists and psychologists to do the work that we need to do. So what we really had to do was think of more collaborative models. So as the last days of the time I was at Medicaid, and very proud of this, is that we launched a collaborative care model. And it was a collaboration with our medical director, who was incredible in his work, but with our Med Society, with the Psychiatrist Association, with primary care physicians on that side, all collaborating to come up with a plan on how do we develop this collaborative care model, which is now in place in North Carolina, and I think has enormous potential to get on the front end, right, to do preventative work in the mental health space, because folks show up their primary care doc and they need that support. But frankly, many primary care physicians just aren't prepared to deal with that. So this model, I think, will change the environment in North Carolina. It'll take time, but we'll change it significantly.
Indeed. So on a related note, I wanted to talk to you about the reality of the healthcare deserts that exist all over America. And I know they are in North Carolina too, be it maternal health or otherwise. They're just simply all too common across the United States. So I was curious, could you share examples of existing healthcare initiatives designed to address the health disparities and challenges faced by communities with disproportionately limited access, including, but certainly not limited to, the Indigenous communities in North Carolina? So, in your perspective, how can we improve upon them to get to the root cause of limited access?
Yeah, it's such a great question. And as I mentioned, in North Carolina, some places in North Carolina, it's not just the frankly rural areas. In some of our urban areas, you'll see the same thing. Is what we have is again outcomes that are just terrible, right? That no one can be proud of, and it is unfair for those communities. It's just unfair for the individuals that live there. The couple of things that just immediately we began to recognize, and one of them is we talked about, is how do you actually get the kind of healthcare professionals that you need in those communities. One of the things that clearly is the case is that if a healthcare professional came from that community, they wind up having a much greater chance of going back to the community. This is probably, I'm going to say this the right way, it's very difficult to get somebody that grew up in Raleigh to wind up practicing in Ohoski, which is a real small town outside of, in the northern part of the state. So one of the things that we began working on across the department is how do we make sure that those folks that may come from the communities to where maybe didn't have the best education system, right, because of the way it's in, but how do we make sure that they have access to get into med school or nursing school and then have their loans repaid so that they're not in a position where they can't go back and reside. So that big question of how do we make sure that people are practicing in those communities, I think, is a critical issue there. The other thing that I think we've learned so much, and I mentioned the social drivers and determinants early, is that we know, right, the truth about healthcare is that we all need those primary care docs. We need the folks in those communities. But honestly, it's about what happens outside of the physician's office that makes such a significant difference in the lives of individuals. And so one of the things that, again, we're most proud of is that, and I'll mention this, we crossed over federal administrations and crossed over state administrations to get a large demonstration project in Medicaid around social determinants of health. And the thing that was so exciting about that to me, Sheena, was that this was not, sometimes the healthcare issues get politicized. This wasn't politicized. It was Republicans, Democrats all knew that if we don't address these issues, we're really not going to get ahead of how we have to go forward. So this initiative in North Carolina right now, there are three areas in the state that we're doing a really intense pilot running through our managed care programs, but really working closely with community organizations to engage them. And we talk about, community health workers to make sure that local community, but frankly, addressing issues around housing, around food insecurity, and transportation has been one of those critical moments that we've been working with those communities to do. Still a long way to go to get the results of it, but I'm confident that's going to make a significant difference. And then I just have to mention, I'll mention it multiple times, is that, honestly, the additional of postpartum care for that year was a critical issue for these rural communities. We had to make sure that people get that service. And one of the best things that happened in North Carolina is that we expanded Medicaid, and it actually takes place December 1st. It goes live. It's a 10-year effort to try to get there, but that will create a very different dynamic for those individuals. If you know how this goes, right? You can, if you don't have health insurance, the only option you really have is showing up at a clinic or at the emergency department. But if we get people insured, we can really use those efforts to get that preventative care, work with those social determinants in front of folks. And so I think that's going to have such a significant impact on those communities in North Carolina that it's not innovative, but it was the right thing to do, right, to get coverage.
Oh, absolutely. I really feel significant impact is about to be realized. And I think that's a result of the many years of good efforts put in by you and your team. So yeah, absolutely looking forward to seeing how that unfolds. So switching gears a bit, during your tenure, state Medicaid moved from a traditional fee-for-service model to one in which the provider organizations receive fixed monthly payments for every patient seen and treated. So could you share more about your perspectives on payment reform and its ability to impact outcomes?
Absolutely. So the shift to managed care in North Carolina was a long time coming, and I think people have different opinions, right? Some folks don't like it. Some people think it's the best thing since sliced bread. But the truth is that as we were moving to managed care, what I think the department did, as we worked with our members of the General Assembly, is that recognize that if we're going to do this, it's just not, you can't do it just to shift to managed care. Because that, you get certain cost containment issues there. But if you're not going to improve outcomes, if you're not going to anticipate that proven outcomes and change the way payments are made, then there's no reason to do it, right? It's just multiple other things you can do. So several things that I think were really important in the transition for us. One is that we recognize that, it's at a community level, right? A statewide managed care organization has to do their work, but if you don't have care management at that local level to really work with individuals, to really work with patients and providers in that process, then it's not going to work. So we had a robust care management system that's embedded into the managed care system. I mentioned earlier the primary care side of this was so critical. So we really emphasize that for our providers, those healthcare companies, they had to have a robust network of those primary care docs as well as everybody else, but really make sure that we could see that as they were going forward in an effort. And then, when we talk about payment reform, there are multiple facets of that, right? Is that obviously we ought to be paying for outcomes. We'd not be just paying for everybody, when you see somebody do these things. But we also have to think about the burden that's on those physicians and other people. So, you've got Medicare payment reforms, you got Medicaid payment reforms, you got commercial healthcare payment reforms. So what we tried to do is align those things together. And so we weren't just adding another burden on top of providers who's doing that work. Now, what I'll say is that,
Right.
the jury's still out. There's a long way to go in terms of determining whether those outcomes are there. But in Medicaid, there are so many things you can do inside of managed care that you can't do in a fee-for-service system. So payment reform is
Right.
top of that list. Care management work was critical that we did it that way. And then I'll just add again the social determinants. We could not have done that without a managed care platform inside of North Carolina. And I'll just add one last thing is that in the years leading up to expansion, one of the things that our General Assembly said is that you had to move to managed care to get control over cost. There was other things to make it happen. It had to be successful. And so again, I'll credit the incredible team that we had in the state to do this work. That was one of the reasons that the General Assembly said they were willing to expand Medicaid, is because we did that successful movement and they felt comfortable that the program could be managed in that system going forward. So it was a lot of things that were really important about it in North Carolina, and that was one of the additional benefits of it.
That's quite interesting to hear, and it's wonderful to see how all the parts and pieces were working together for the success and improved outcomes of North Carolinians. It's really exciting. So just my last question here, and we've sort of been maybe weaving through indirectly this topic throughout, but I sort of just wanted to ask plain and simple. So from your perspective, what do you see as the most promising areas for innovation in Medicaid and public health policy in the coming years? And, moreover, what valuable insights have you gained during your esteemed career about the interplay between innovation, public health, and public policy? So it's a big question, but love to hear your thoughts.
Yeah. So let me start out with two things real quickly, and then I think this big interplay question is a harder one. I think technology, and again, I'll use the work that you guys are doing at CognitiveCare, right? Is that the ability to use technology to advance healthcare outcomes is something I think we're just touching the surface on. The work around how do you predict who are the folks that will need the sort of early intervention that we can get in front of people is critical. It's not only critical, and you guys taught me this, right? It's critical for alignment of that, but it's also critical about how you align resources. And I will say inside of our program, that was one of the biggest challenges, right? How do you make sure that the resources are directed to the right folks? So I think that the technology changes, this kind of work that you're doing is one of the most important innovations that we have. And it's only going to get more important as we go forward, right? Because we have all of the continued improvements on that, and we'll think better about how to use it. I also, and I overemphasize this maybe, but I think thinking about, frankly, technology, but across the board in the social drivers is absolutely there. We're just touching the surface about what makes a difference. One of the things that was absolutely clear in the behavioral health work we did, and frankly, in my terms in long-term care, is that if you don't have housing, all the behavioral health work that you want to do can make a difference, but it's not going to make the difference, right? You cannot stay on your meds. You can't do all the other things you need to do if you don't have stable housing. Well, we've got to figure that out. And often people say, well, that's not Medicaid's job. Frankly, it is. It's our job to work with the community to make sure that people are stable. One quick story. I went to a dinner early in my career at Medicaid where they were giving awards out. And one of the awards they gave to was a organization that created a group home for where homeless people, when they left the hospital, they had a place to go for their recovery time. And I'm embarrassed to say I never thought about that before, right? But it was so dang simple, because that's what they were saying, is that you discharge somebody that just had a significant, maybe a heart surgery to the streets. Well, they're not going to be able to follow the plans that you need to do. But if they had this group home, now we need to do way better, right? It shouldn't be just a group home, people would be housed, but it's that kind of thought process that I think are the right innovations. And when you think about how do we all intersect this stuff, this is what I believe is the part that we've not done so well over the years. Is it the old time? I'm not being political here, but when we talked about it takes a village, right? Well, the truth is that we as state government agencies and federal government agencies often get so siloed that we forget to think about the people that work across the boards. I had great interaction with one of these community organizations that frankly during COVID was doing testing and frankly providing food to people as they came through, because people were having such a hard time. And in the conversation with this, one has learned a lot, right? So people came because they needed food, but they also got the testing that they needed. And if they needed service, they got it there. But in this community, it was a very low income community that social service agency was the most important. Then I got a quick lesson from him too. He said, you guys as a state are doing some real cool stuff about, we have a closed loop referral system that we were using. That sounds great to refer people, but y'all are just so, he frankly used the word, it's a bunch of yuppies running that program. I hadn't heard the yuppie word in a long time. But what he was basically saying is that you have to recognize when you get down to communities that sometimes the people doing the hard work aren't the people that have the time to learn about all these systems that you're putting in place. So all that to say is I think the intersection to me is that it is between social drivers, it's between healthcare, and it's through those community organizations that already do great work in communities. And honestly, we can do all sorts of back room functions with all the technology and everything else that's there, but we've got to make it easy to use for people in those communities so they can actually do things that are actionable at that level. So we have a long way to go, but I am so dang excited about the chances that we have to make really revolutionize health in our, frankly, across the board, but frankly, health in places where we have these incredible disparities that I think we can make a huge difference on. I hope that was it. I got excited about the question, so I may have missed some of it.
I'll say your reasonable optimism is very inspiring. So I that was a fabulous answer because it gives us a lot to think about. Dave, I really want to thank you for sharing your insights, your experience, and your wisdom with our audience. Any closing comments before we conclude?
The one thing I'd say again is I think the right optimism is it. There are so many things going on in our world today that sometimes it's easy to not be optimistic. But honestly, we have incredibly bright people. We have incredible new technology that you guys are doing. And that if we all figure out how to just work together in this stuff and then break down those barriers, I think we have a chance to make a huge difference in the lives of individuals. And frankly, that's what this is about, right? It's about the individuals that we all care about and want to make sure they have the high quality of life they have. Because if you have good health, you have a much better chance of having that quality of life that we all dream of.
Oh, that's so wonderful to hear. And I think a wonderful place to conclude this episode. After hearing you speak, I'm very hopeful that innovation can help advance outcomes that interplay with public policy at individual and population levels. So thank you so much, Dave. It was a pleasure having you. And to our audience, thank you so much for tuning in. And until next time, be well.